Bismillah ar-Rahman ar-Rahim. Hello, everyone. You are welcome again in Ziada Academy Zoom meetings. And it's the first day of the new year. And to be a happy year, I'm bringing a great gift for you today by hosting one of the experts in the cataract and refractive surgery, our Professor Dr. Ahmed Al-Masry, Professor of Ophthalmology, Alexandria University, Egypt. And he is an expert in the field of the cataract and refractive surgery as well. And today he will talk about an important topic about the keratoconus in some different ways about the keratoconus in unusual way we used to talk about. So I will let you listen and enjoy his talk about this important item. Thank you, sir, for your time and for accepting my invitation today.
Thank you so much, Dr. Hassan, for this invitation. It's my pleasure and honor to be with you today. And we're going to discuss the problem of keratoconus and thyroid gland dysfunction.
Yes, sir. Can you share your screen, please?
Okay. Is it okay?
Yes, I can see it now.
Okay. So maybe the topic of today is relatively an unusual topic, but honestly, it's a hot point that should be discussed and should be put in mind for every ophthalmic surgeon or any ophthalmologist who is dealing with patients with the keratoconus. It's my honor to be this work to be done with Dr. Randleman, and I have no financial interest of this topic. I'd like also to thank Dr. Mahmoud Abdelati, who helped me in the preparation of this presentation. Simply, I'm a reviewer. Maybe we're going to take the presentation as a story. I hope to be interested for you. I'm a reviewer for the Journal of Refractive Surgery, and I received a request for reviewing a case report titled Bilateral Keratoconus Induced by Secondary Hypothyroidism After Radioactive Iodine Therapy. The title of the paper itself is a little bit was strange for me. Is there any relation between the keratoconus and the thyroid gland dysfunction in general or not? So simply before starting the revising the paper, just summarize the paper that had been published in the Journal of Refractive Surgery by Randleman and Farhat Hafizi for a 53-year-old female with late onset and progression of bilateral keratoconus. She didn't have previous keratoconus before. She's not post-refractive ectasia. There was no rubbing, no trauma, nothing at all of this. And this was its presentation. And the only point is the patient had a continuous diminution of vision by time and just blepharitis, and the steepening and thinning of the cornea was progressive in spite of being 53 years of age. We know that at that age, usually the patients with keratoconus are stable and don't show any progression. And the thyroid disease, this was very astonishing for me. And while I'm just thinking in the paper, I found a very old file that days of the paperwork for a lady. She came to me in 1994, which is now 26 years. And I found that she had thyrotoxic exophthalmos. And at the same time, I wrote that I cross-linked her on 2007. So I said, what is the relation in my patients between the thyroid gland dysfunction and the keratoconus? So let's know what happened for this girl. She was 17-year-old female, presented in 1994 with a history of Graves' disease, and she had partial thyroidectomy, and she was euthyroid after that time. And for the period of post-operative follow-up, at that time, she didn't complain of anything, and her baseline ophthalmic examination before the partial thyroidectomy was totally normal, and the visual acuity was 20/20 in each eye, +1 sphere, like any normal individual. And then 13 years later of regular follow-up for regular blepharitis and regular vision for for any patient, she started to show right eye affection in 2007. And at the time, there was no pentacam, so we did topography for her, and she represented in 2007 at the age of 29 years, which is relatively, again, an old age for start of keratoconus, with decreased visual acuity in her right eye, and the vision reached 2030 unexplained, and 2020 in the left eye, with the manifest astigmatism of 2.5 diopters in the right eye and 1.5 diopter in the left eye. As I said, at that time, there was no pentacam, so we did just topography and found there is steepening in the right eye, which is definitely keratoconus. We know that keratoconus is a disease that diagnosed by topography mainly. So we decided to cross-link her at 2007, and she was one of the earliest cases that we did cross-linking for her in Egypt in general, because we started cross-linking at 2006. And simply it was the Dresden protocol with the epi off 9 millimeter of the epithelium, and soaking time was 30 minutes with an intensity of 3 milliwatt. And then we put her under ultraviolet A radiation after putting the riboflavin for half an hour. The usual Dresden protocol that we are using even now, and some people are still using the Dresden protocol for treatment of cross-linking. And as you all know, there's a comparison between the regular Dresden protocol and the accelerated one, epi-off and epi-on and iontophoresis. At that time, we didn't have the option except of the classical Dresden protocol. Follow-up of the patient showed non-progression of the right eye, and the left eye was okay. Of course, she was not a case to be cross-linked bilaterally, and the concept of bilateral cross-linking for a patient with one eye keratoconus was not at that time propagated, because at the time, if the patient has keratoconus in one eye, we just cross-link that eye. But now, if you have a patient with keratoconus in one eye and any changes in the other eye, we don't wait, we do cross-linking for both eyes, because we know that keratoconus is a bilateral disease. Again, follow up in 2009, the same situation, and very starting early, some progression in the left eye, but the patient was seeing normal. At 2011, when we had the pentacam, as you see here, of the right eye is normal, but the left eye showed steepening of the inferior part, with difference of about 4 diopters between the inferior and superior halves, and the posterior float also started to increase. But please put these numbers in your mind. It was just the difference here is 9 and here is 17, and the patient was seeing again 2020, so we put her under follow-up. Then at 2016, we lost her follow-up at that time for 5 years, and she became 39 years of age. And we know, of course, at that time, usually these patients are stable and they don't show any progression of keratoconus. And the routine follow-up evaluation revealed that best corrected visual acuity was 20/20 in each eye, with the manifest refraction was nearly the same, but the left eye showed some progression of the astigmatism in the left eye. And again, tomography was stable in the right eye. However, there was mild steepening of the left eye and thinning of the left eye. And that time, again, we said still she has good vision, so the no intervention and follow-up was our choice. Again, this is the 2016 with the steepening again that a little bit increased, and still remember these numbers. And now it's starting to progress more on the posterior float, and the numbers are increasing. In 2017, the patient obtained serum thyroid hormone levels in anticipation of surgical removal of bilateral ovarian cysts, and was found that the T3 and T4 were within normal age, and the TSH level was markedly decreased. So she was hypothyroid at that time and not an euthyroid patient. And she was evaluated by her endocrinologist, showing bilateral enlargement of thyroid lobes, and she received treatment. And here is the her thyroid situation, and she was decided to remove the thyroid, the ovarian cyst at that time. But her ophthalmic examination at that time showed that the best corrected visual acuity still is 20/30 in the right eye and had decreased in the left eye. And with increase in manifest astigmatism to 2.5 diopters in the right eye and 5 diopters in the left eye, which definitely bothered her and bothered her situation and her vision. And the pentacam imaging showed that there was a stable finding in the right eye, but there is a progressive inferior steepening in the left eye. In 2017, the right eye is stable, no progression. Cross-linking that had been done in 2007 was still working after 10 years. And this is another very important message to send to the ophthalmic surgeons who are doing cross-linking, that just once is enough. It's 10 years and still the cross-linking is working. There is no need to repeat it. But on the left eye, as you remember, these numbers were 17 and 18 and reached now the posterior floats up to 57. So there is marked increase in the posterior floats, and there is marked increase in the difference between the inferior superior halves, and definitely this patient is indicated for cross-linking her left eye. Doing OR for her showed that the corneal hysteresis and the corneal resistance factors in the right eye, which was the cross-link one, is much, much more than in the left eye. And this is an indicator for the biomechanics of the cornea, showing that definitely these biomechanics decrease with the weak tissues of the cornea that have been not cross-linked in the left eye. So we decided to do accelerated epi-off cross-linking in her left eye in 2017, after 10 years of the first eye. And simply it was an epi-off accelerated cross-linking with soaking time of 30 minutes of riboflavin, and the intensity was 18 milliwatt for 5 minutes, the usual that we are doing now for the epi-off accelerated cross-linking. So from this, we went back to review the literature. What's the relation between the thyroid eye disease and keratoconus? And there's a pathophysiology that the patients with thyroid gland dysfunction have elevated levels of thyroxine in both the tear film and the aqueous humor, which may cause biomechanical changes in the corneal stroma due to thyroxine receptor interactions. And this had been proved by these papers in 2017, 16, and the old one, 1990. And for more details, tear film thyroxine levels are elevated regardless of the blood thyroxine level. So there is high level of tear film thyroxine, regardless the blood thyroxine level. That's why we say that there is a problem of the cornea with the thyroid gland dysfunction, whether the patient is euthyroid or hypothyroid or hyperthyroid. This is the comparison showing that the patient's keratoconus, they show marked levels of thyroid film thyroxine at that time for tear film thyroxine. And the inadequate use of tear thyroxine by the cornea of keratoconus patients is suggested either by changes in the transformation of the thyroxine to triiodothyronine or ineffective binding of thyroxine by receptors at that time. So simply, the direct effect of thyroxine on normal keratocytes metabolism is to inhibit the inflammatory process and stimulation of keratocyte proliferation in vitro that has been approved in vitro, and the effect is reversed in case of keratoconus. So thyroxine is important for the collagens of the cornea to be stiff, and if it is abnormal, there is a problem of keratoconus. This is the theory or the suggestion, and was suggested to be due to modified expression of thyroxine receptors by corneal keratocytes. So the thyroid dysfunction prevalence among patients with keratoconus had reached in some papers up to 13.6%. And this number actually is very high to the normal population, which is about 2%. But definitely these numbers is related to the ethnic situation, the geographical distribution, and many other factors. And the T34 was higher in keratoconus patients, and keratocyte thyroxine receptors were elevated in patients with keratoconus. So the collagen and the cytokeratins were equally altered both in keratoconus and in cultured corneas substituted with T4. So there is a big or a strong relation between the thyroxine and the keratoconus. This is one of the papers that had been published of the role of thyroxine in the development of keratoconus. to summarize that, the data showed there is a crucial role of T4 in keratoconus pathophysiology, which is most likely mediated by T4RS. Another case reports for a 10-year-old boy with Hashimoto's disease, or 12-year-old boy with Down syndrome and hypothyroidism, 33-year-old pregnant woman with hypothyroxinemia, and they developed keratoconus. So this allowed us to publish our work, or our case report of bilateral asymmetric keratoconus induced by the thyrotoxicosis with long-term stability after corneal cross-linking, and it had been published in 2018 in the Journal of Refractive Surgery. And we said we have to see what's happening in our country, in Egypt, regarding the patients with keratoconus and their EU or their thyroid gland dysfunction. So we decided to make a cross-sectional case control study that had been again published in 2020 in the Journal of Refractive Surgery. We compared our patients, and we started to collect the data after publishing the first one in 2018 up to July 2019 to know what is the situation in Egypt regarding the keratoconus and the thyroid. And the study was done on 187 patients with keratoconus, and we took as a comparative study 187 of normal population. This 187 patients with keratoconus, as had been approved by Pentacam regarding the steep and the flat meridia and the K readings and the thinnest part of the cornea, whether had been cross-linked or had intracorneal ring segment implantation, or even patients that did DALC or any other procedures for treating keratoconus, but they had been approved. There were keratoconus, and these were compared to 187 normal individuals, and taking the free T3, free T4, and the TSH for all of them. We found that 10 out of 187 patients with keratoconus, compared to 2 out of 87 patients of normal individuals, showed high levels of T3, T4, and TSH. When reaching the fact of 5.2% of patients with keratoconus have thyroid gland dysfunction in comparison to the normal population of 1.1%, which is comparable to the other studies. But this number of 5.2% of patients with keratoconus, they have a thyroid problem, definitely raised an alarm, a red alarm, that we have to consider the situation of the thyroid gland and the keratoconus. So we concluded 7 wisdoms from this presentation, and we have to put them in our minds as we are treating patients with keratoconus. The first one is keratoconus is a bilateral disease. Wherever or whenever even one eye is affected, definitely the other eye will be affected even after many years, 10 or even 15 years, but the other eye will definitely be affected. So it's a bilateral disease. The second thing, definitely there's an association between the thyroid gland dysfunction and keratoconus. Third, 5.2% of patients with keratoconus, they have thyroid gland dysfunction. The fourth wisdom is we have to order free T3, free T4, and TSH for all cases of keratoconus, because you may save these patients for another complications from the thyroid gland dysfunction if it's discovered early. The fifth is there is an asymmetric presentation of thyroid-induced keratoconus. The sixth wisdom is cross-linking had a long-term stabilizing effect over 10 years, like had been approved in the presentation of our young lady, despite the ongoing effects of thyroid gland dysfunction. And the last and the most important wisdom that I put in mind now is I prefer to avoid refractive surgery in patients with thyroid gland dysfunction, as they may have hidden keratoconus or probability of inducing ectasia after the surgery. Thank you so much.
Thank you, Dr. Ahmed, for this great presentation and wonderful work. It's really a wonderful work, full of information and the research tools about this fact. It's very high percentage to find that the keratoconus association with the thyroid gland 5.3 instead of 1.1, and the normal individuals It's very significant. I think it's highly statistically significant finding.
Yes, sure. Sure.
So sir, we can say at the end of this presentation that the keratoconus in such patients is induced by the thyroid, not associated with it.
Induced, yes, you can say that it could be induced by the thyroid gland dysfunction, not only associated with it.
Yeah, it's very important item to consider, because some people were saying that that the keratoconus is just an association with this thyroid disease, not a cause or a complication to it.
Yes, that's right. But now I think it's clear that there is a role of the level of the thyroid in tear film layer, and this affects the inflammatory mediators of the keratocytes. And if this thyroid level is low, the inflammatory mediators, which are responsible for having strong keratocytes, are not present. And so they can cause the keratoconus by weakening of the collagens and the keratocytes.
Yeah, okay, so you announced about the seventh wisdom: don't
Yes.
do refractive surgery in thyroid
Yes.
in a patient, in a person with thyroid dysfunction.
Definitely,
Even
I do insist now of avoiding doing refractive surgery for any patient who has abnormal thyroid gland dysfunction or even history of previous thyroid gland dysfunction. Because the point is, you are doing the refractive surgery for 25, 30 years of age patient and seeking the freedom from glasses. But these patients, if they have abnormal thyroid dysfunction, thyroid gland dysfunction, definitely there will be problems by the age of 50 and the 55. So why to subject these patients for later complications that could be avoided by simple procedure of avoiding doing the refractive surgery for these patients?
yeah, even if I have a very normal pentagram, yeah,
Yes, even if you have normal cornea, like the collagen disease, you have
yeah,
an absolutely perfect cornea, but the lady is systemic lupus. So we don't dare to do refractive surgery for any autoimmune disease.
yeah,
And it is the same principle for the thyroid. But the question is for the diabetics, are you going to do or not to do? This is still debatable for the diabetics because we have now many young diabetics that are seeking refractive surgery. So it's not an absolute contraindication. It could be for some well-known surgeons, it is a relative contraindication, but I know that a lot of surgeons are doing refractive surgery for diabetics with no problem in most of the cases. But again, for the thyroid, I prefer to avoid total refractive surgery.
yeah. Okay, I agree with you, sir, about that. The thyroid disease, there is a biomechanical changes, biochemical changes with biomechanical changes.
That's right.
But about the diabetes, do you mean that the diabetic related complication inside the eye or on the cornea itself?
You know that for the cornea itself, for the diabetics, just decrease in the corneal sensation as a cornea per se. But the point is, if you're going to do PRK for the healing of the epithelium or the healing of the flap itself, it is still questionable whether they will react normally or you may face problems for these patients. So I'm doing for diabetics. Actually, I'm not putting the diabetes as an absolute contraindication, but the patient should be very well selected. The patient should be well oriented. He knows what's the problem. He knows there may be some problems. He's convinced with the refractive surgery, not to push him for refractive surgery.
Yeah, strict control, good
Strict control of diabetes, HbA1c, the fundus, and everything should be under control.
and the stable refraction because of the
Of course, the fluctuations with the hypo and hyperglycemia.
Okay. Okay, so let me ask about the other side of the thyroid gland disease, which is the hyperthyroidism, the autoimmune hyperthyroidism. It's also considerable like the hypothyroidism.
Yes, if you notice in the paper that had been published in 2016, that what he did is taking the T3 and T4 and TSH from the tear film layer.
Yes.
From the tear film layer, and he found in the hypo and the AU. And the hyperthyroid state, any thyroid gland dysfunction, there is a more difference in the T3, T4, TSH in the tiers than the normal individuals. That's why we say thyroid gland dysfunction, regardless the patient is euthyroid, hypo, or hyperthyroid.
Yeah. Okay, it's the total identity
It is
of
itself, yes.
functions. Okay, so it will close a lot of doors in front of the refractive surgery, because we have a lot of patients with indefinite history. So we have to reconsider the full checking of our patients before going to surgery. So to ask for this thyroid gland profile before, especially if we have any suspicion about that, or history, or especially in the females.
Yes, that's right.
Okay. There is another point you have mentioned, sir, in your presentation about the Hashimoto's disease. This means that all collagen diseases, autoimmune diseases, like the rheumatoid arthritis, like the other, either seronegative, seropositive autoimmune disease, I have to check the cornea.
Yes, this is the other point.
With the rheumatologist,
we are pushing the endocrinologists now, the patients with thyroid dysfunction or any other collagen disease, to just have an ophthalmic checkup, not only for the extraocular muscles and the proptosis and so for the thyroid, but also for the cornea itself. That's why we are in a work of that we're doing to see how many of the patients with the thyroid gland dysfunction, they have an abnormal cornea. So bringing patients with thyroid gland dysfunctions and doing pentacam for them, and to see if there's an abnormality in the corneas of the patients of thyroid gland dysfunction or not. The other way.
Yeah, perfect. I'm doing work now with a rheumatologist, one of my colleagues in dermatology, about we are gonna studying the corneal changes with the in rheumatic patients after dividing these patients for mild, moderate, and severe disease, about the changes in the corneal thickness, especially in the peripheral part of the cornea. But it's a good idea, which I got from this presentation now, to consider the topographical changes in such which I may find some changes too.
Yes. Why not to do simple topography for those patients? Definitely have good data.
Okay, thank you, sir. It's really a great presentation and very beneficial for all of us. But let's go back to the first wisdom. The
keratoconus is a
bilateral disease. So we have to cross-link if we find any changes in one eye?
Yes. This is definitely yes.
I totally agree with you, sir, but a lot of surgeons should in conflicts about that. We are waiting until the problem to happen and then think, and it's not logic, I think.
Yes, I do agree that we have to cross-link both eyes for any patient, even with unilateral keratoconus. And what's more, as long as in the old age, even in patients with old age, if they have progressive keratoconus in one eye, please cross-link the other eye. Another important message, which is a little bit outside our topic, is if you have a patient with that did LASIK and he has keratectasia in one eye, please cross-link both eyes, because sooner or later the other eye will develop keratectasia.
This was my next question about the post ectasia.
Yes.
Okay. So even if there is no any abnormality or any
yes.
I think the abnormalities in the sound eye is still hidden, but it's coming.
Yes, it's coming sooner or later.
Yeah, and I have I had a meeting with Dr. Yasser Rifai from Morocco, who's my close friend. I think you have met him in Morocco, or you know him, about the epithelial mapping, which could discover the keratoconus before any pentacam changes by the epithelial mapping, by the donut formation.
Yes.
So it may be helpful in that to start cross-linking bilaterally. And as you said, sir, bilaterally, in the post-LASIK ectasia. Yeah. Okay. The last question. I know that I took a lot a long time from your holiday.
Not at all. It's my pleasure.
Thank you very much. The last question about the dry eye, the feeling of the dry eye or the symptoms of dry eye in such patients. It will be affected by the thyroid dysfunction too.
It could be a point to be discussed. Actually, there are no such researches on this point. There is nothing evidence-based medicine that the patients with thyroid gland dysfunction, they have more dry eye, like we know in patients with rheumatoid or other collagen diseases. But again, even without proptosis, it's a very good point to be discussed and to be searched for. Yes,
let's go ahead to look for it. Because biochemical changes in the cornea could be in the conjunctiva and also in the
yes, definitely yes.
Thank you, Professor Ahmed Masry, Professor of Ophthalmology, Alexandria University, and our teacher and the expert in the cataract and refractive surgery. Thank you so much, and please give me a promise and the whole audience today, in the first day of the new year, to get your highness again.
Sure, I promise you to discuss the point of cataract and keratoconus maybe next Friday. We can arrange a date next week, inshallah.
Okay, thank you, sir. Done.
Thank you so much, Hassan.
See you. Bye.
Bye.